Bismillah ar-Rahman ar-Rahim. Dear respected professors, colleagues, general audience, it is with great pleasure to be presenting at the second International Psychiatric Conference, Lahore, Pakistan. And my topic is about depressive disorder in children and adolescent assessment and treatment. Before I start, these are my disclosures. I have nothing to declare, and I have no conflict of interest with any pharmaceutical companies. And the depressive disorders in children and adolescents is a big topic, obviously. However, I would like to share with you in the next while some DSM criteria, ways to assess depressive disorders and treatment intervention. And we would also reflect on some of the epidemiology and course of illness, and we would like also to shed some light on the warning against antidepressant use in young population. Ultimately, I don't have much time to cover all these topics, so my focus will be on the major depressive disorder as per DSM-5. I may also shed light on the new diagnosis of disruptive mood dysregulation disorder in children and I may also shed some light on the persistent depressive disorder. What are some of the major differences between DSM-4 and DSM-5? People who are using DSM-5 would notice that there is now a separate chapter for depressive disorder and instead of mood disorders together. Dysthymia now come under persistent depressive disorder, and they've added two new categories: the disruptive mood dysregulation disorder and premenstrual dysphoric disorder. Bereavement as an exclusionary criteria has been removed. A question comes to mind: children be depressed? The answer is yes. Needless to say, youth, young adult, and we know more than before that there is a high rate of comorbidity. The disorder are prevalent and recurrent, and accompanied by poor psychosocial outcomes. In the WHO key facts from 2019, depression is a common mental disorder. Globally, more than 264 million people of all ages suffer from depression. Depression is the leading cause of disability worldwide and is a major contributor to the overall global burden of disease. More women than men affected by depression, and it leads to suicide, where close to 800,000 people die due to suicide every year. Suicide is actually the second leading cause of death in young ages, 15 to 29. The good news, there are effective psychological and pharmacological treatment for moderate and severe depression. In children, and if identified, detected early, and intervention introduced early, then we can actually prevent a lot of complication, because it can cause school failure, dropout, and needless to say, the children and youth might get into suicidal behavior, substance abuse as a way of self-medicating and alleviating the severity of the depression. Can be also associated with or as a result of physical illness, early pregnancy in female youth, and poor academic performance, as mentioned. Here about a few words about the disruptive mood dysregulation disorder. And I remember, and those my colleagues, child and adolescent psychiatrists or adult psychiatrists who used to see children, we were struggling 20 years, 30 years ago, when we are faced with children whom do not necessarily meet the criteria for bipolar, not the severe form of ADHD. And we were always wondering, what is it, and what kind of medication, what kind of treatment intervention we might pursue. Luckily, and that with the longitudinal research and scientists and researchers got together, and we were able to introduce this as non-disruptive mood dysregulation disorder. And it's characterized by severe recurrent temper outbursts that grossly out of proportion in intensity and duration. Occur 3 or more times each week for 1 year or more. Between outbursts, and this is very important, which I highlighted in red, mood persistently negative, irritable, angry, or sad, most of the day and nearly every day. This is to differentiate it from oppositional defiant disorder, to some extent from bipolar, as well as severe form of ADHD. Symptom must be severe and present in at least 2 settings, home, school, or with peers for 12 or more months. Onset must be before age 10, in a child at least age 6. As I said, the intent of introducing such a diagnosis in DSM, and I believe in ICD-11, is to capture children with frequent temper tantrums that previously were misdiagnosed with bipolar disorder, as more severe anger and mood dysregulation. Bipolar is episodic, wherein DMDD is more non-episodic. Children with DMDD are at risk of future depression, anxiety disorder. Longitudinal follow-up of DMDD shows that they do not change into bipolar as they age. A few words on persistent depressive disorder, which we know it in the adult population, previously known as dysthymia. The key element or the differentiating factor to keep in mind for children and adolescents, instead of 2 years of the symptom that meet the criteria for persistent depressive disorder or dysthymia, it is only 1 year, and at least 2 other symptoms, and it causes a significant impairment. Here we will be more focusing on the major depressive disorder. To date, we're still using the adult diagnostic criteria, and I hope in the future that we will have modified diagnostic criteria that more suits the need for diagnosing depression in children and adolescents. And you will see in a few minutes some of the differentiating features that's more geared toward children, adolescent compared to adults. So again, it's 2 weeks or more with a change in functioning associated with at least one of the symptoms, depressed mood and or loss of interest, associated with other symptoms, where we need 5 other symptoms: significant weight loss or weight gain, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feeling of worthlessness or excessive guilt, diminished ability to think or concentrate, suicidal ideation and plan. And when I mentioned that we hope to have modified features, because again, these are all generic symptoms, but when you apply it to children, to adolescents, compared to adults, the interpretation of it is a bit different. And those who work with children and adolescents would appreciate what I'm saying. So we have to be really careful. And when a child or a youth present with depressive symptom, may not necessarily be similar of what we see in the adult population. Of course, it causes significant distress or impairment in social, occupational, or other important areas of function. So with children and adolescents will be school. Symptoms do not attribute to substance abuse or another medical condition, though it can co-occur. And as I mentioned earlier, if not treated, the youth is at high risk to use substances. The depressive episode not better explained by other psychiatric illness like schizoaffective disorder, schizophrenia. etc. And there has never been a manic or hypomanic episode. As for the severity, if there is less or equal force symptom, but no suicide ideation or psychosis, intensity is distressing but manageable. This is to consider to be mild, versus severe, where you would expect more symptom, more than 4, with presence of suicidal ideation, could be in the presence of psychotic features, mixed features, and in the intensity of symptom is seriously distressing and unmanageable. And moderate, obviously, will be in between. What do we know about depression in children? As I said, some of the audience might wonder while I'm presenting this topic that, do you really mean that children get depressed? They're just innocent, young people, had nothing, like had not seen yet of life. How come they become depressed? But studies and statistics show that depression in children under 12 years of age is less prevalent. However, it is there. Has been successfully and reliably diagnosed in children as young as 3 years old. Significantly less evident on the treatment of depression in children and their adolescent counterparts. And again, when I talk about children and adolescents suffering from depression, most of the data, most of the statistics, most of the treatment intervention are coming from the Western Hemisphere. So it is our job to also do our homework and study the prevalence rate, the presentation of depression in children and adolescents in our region, and find out what mode of treatment biopsychosocial have been working best for our kids and youth. This slide is very important, and I could spend a good 15 minutes, but due to the time, I would just read through that differentiate and help the clinicians, the psychiatrists, and others to recognize or predict child and adolescent with depression. So in younger children, 12 and younger, more symptom of anxiety, phobias, separation anxiety, somatic complaints quite common. Some kids might present as a first presenting symptom auditory hallucination, and I've seen it and I treated it a few times, and it was nothing but because of underlying depression. Express irritability with temper tantrums and behavioral problems. In comparison to adolescents, have few delusions, less serious suicidal attempts, if any. As for the adolescents, we compare them more or less with young adults and adults. More sleep and appetite disturbances, more delusions, more suicide ideation and acts, impairment of functioning, and compared to adults, more behavioral problems, fewer neurovegetative symptoms. Few statistics important to know that pediatric MDD is often underdiagnosed and undertreated, with only 50% of adolescents diagnosed before reaching adulthood. Major depressive episode often improve and remit within 7 to 9 months of symptom onset. However, children and adolescents who have recovered after treatment often have recurrence within 2 years, with 70% incident by year 5. Male to female, when they're younger, it's 1-to-1. As they grow up into adolescent, it's 1 male to 2 females. And major depressive disorder prevalence rate, although you might read in different study, different figures, but this is the most, I would say, commonly or mostly acceptable. 2% in children, 4 to 8, up to 12% in adolescents. Risk factors for onset of pediatric depression, I wouldn't go over all of them, But obviously the child, the youth can have one or more of these risk factors. And I will leave it to you to read through. Course and outcome, I've already mentioned a few statistics before, but here I would like to emphasize that suicide behavior is common sequelae of early onset depression, and early onset depression is also where we have difficulty with the treatment intervention, and they tend to resist, and it takes longer than expected to respond to treatment. Mortality due to suicide is elevated at least tenfold compared to non-depressed youth. Depression is associated with obesity. And this is very interesting, and I put some reference for you to read. Just quickly, I want to mention or share with you what could be the rationale behind it, although there is nothing conclusive to date. But obesity is actually the trigger for inflammatory process in the body, which is in turn be associated with depression, as some studies suggested. When we talk about etiology, as you can see in the diagram that I'm presenting, I put depression and arrows going in parallel, which means there is no single factor, and in fact, that can cause depression. And in fact, most of the time, if not all the time, there is one or like two or more factors are collectively can cause the depression. Among all the identified risk factor and risk and etiological factors, the biological predisposition and the environmental factors play a major role in causing depression in children and adolescents. Due to the time constraint, I removed a few slides about genetical studies and other neurobiological studies that have been talking about the etiology behind depression in children and adolescents. Some of the environmental factors I meant to present it to you because they're very important. And again, as I said, most of these data or informations are coming from the Western Hemisphere. So each region, the rest of the world might have modified or different altogether environmental risk factors. The good news that resilience, if the child, the youth, is born with inborn resilience, it actually works for them as a protective factor. But also, I can share with you that for those who do not have it to start with, we can help them acquire and develop a resilience, which I have seen many youth when we introduce them to the psychological intervention, particularly CBT and other form of treatment, they tend to do better, and the long-lasting effect is actually guaranteed. Now we come to assessment, and under assessment there are several things that a clinician, a psychiatrist, have to keep in mind. Not necessarily different from the rest of the psychiatric disorder, but information obtained from multiple sources when you're dealing with children and adolescents is quite important compared to adult population. So the child himself, herself, the youth, the parents, teachers, and others. And very important, I want to quickly just highlight something here. Do not underestimate the age. Sometime when we have the child coming to our office or we see them in the community, we tend just to focus, some of us, we tend to focus on talking to the parents and not necessarily paying close attention to the child. It's very important to give the child the space, the opportunity to express themselves. Doesn't have to be through talking, can be through drawing, through playing, and so on, and so on and so forth. Same with the youth. You need to give them a space and get permission to share confidential information. And of course, except if it's safety related, you cannot just keep quiet and pretend nothing is happening. Review of psychiatry history, if any. Review of medical history. As I mentioned, obesity is a risk factor for depression, but there are other medical problem can be the cause of depression. Hypothyroidism is one example. Review of developmental history. A review of academic history can be the trigger. As we said, it can be biological or environmental. School is one of the major factors for some youth or children, causing them anxiety and depression. And review of family psychiatric history, quite important. Assess for comorbidities, assess mental state examination, assess severity and impairment, use of some instruments. And this is something that we like to do, but something to keep in mind. Using a diagnostic instrument does not substitute clinical assessment. The best way, and still is the primary way to diagnose depression and most psychiatric disorder, is listening to the history and do mental state examination. However, there are a few instruments geared and designed toward children and adolescents. And also, as I mentioned earlier, hypothyroidism can be a treatable cause if present with depression. And I cannot emphasize the importance of assess safety. Do not underestimate that he's or she's 9-year-old and cannot or cause any harm to themselves. Well, when they are in that severe mode of depression, may not have the right judgment, or the judgment is most likely impaired for them to keep themselves safe. Needless to say, with older adolescent, with older children, youth, and young adult, and so on. And of course, always to conclude with assessment of level of care, presence of support around the child at home and outside. I'm sorry. In the assessment, it's important to keep in mind differential diagnoses. And as you know, in psychiatric disorders, most of the time, a disorder can present with another psychiatric disorder as a comorbidity, which is my next slide. But sometimes can be also difficult to differentiate it with another disorder that shares some of the features. And as I mentioned earlier, for the DMDD, up until recently, we were really struggled whether this is a bipolar or a severe form of ADHD. So among the differential diagnosis, as you can see, adjustment disorder with depressed mood. I wouldn't go over all of them, but I would just highlight few. Attention deficit hyperactivity. I already mentioned DMDD, eating disorder, and some of the new disorders that were added to DSM-5. Comorbidity, double depression. 40 to 90% of youth with depressive disorder have other psychiatric disorders, with up to 50% having 2 or more comorbid diagnoses. The most frequently presentation: anxiety disorder, disruptive disorder, ADHD, and substance use disorder. Risk for bipolar, 20 to 40%. And some of the indication or the risk factor: early onset of depression, excuse me, depression accompanied by psychotic features, very important family history of bipolar disorder, and pharmacological induced hypomania. And having said that, I would emphasize, although it will come when we talk about treatment and management interventions, I would like to emphasize, in general, even with adults, I tend to start low and go slow. But this is very true when treating depression in children and adolescents. Always start low, take your time, no rush, for two reasons: to prevent potential induced mania or hypomania, but also in young population, there is an increased rate, an increased suicidal ideation, which we will cover toward the end of my presentation. Now we'll move to treatment intervention and management plan. And these are some of my main highlights I would like to cover with the time allowed. Suicide is common. 400 suicide attempts by teens, boys, for every completed suicide in males. In the contrary, 4,000 suicide attempts by teenage girls for every completed suicide in females. And the question, who uses the most effective method, girls or boys? I'll give you 10 seconds to think. Obviously, boys. Profile of youth with completed suicides, and this is very important slide. I wish I have more time to spend to talk about it. But anyway, and I've seen it throughout my career in psychiatry, in child and adolescent psychiatry. Youth with immature problem solving, less able to assess situation realistically. They are more into impulsive behaviors and self-harm behaviors. They're less able to tolerate frustration, and their choices are quite limited, and they have difficulty planning for future to plan future actions, and difficulty making decision, as I mentioned. And they can be also aggressive or violent with violent outbursts, whether this is because of the underlying depression, or maybe because of the use of substances of a self-medicating way. Good news, there are some protective factors, which we would like, again, I would love to spend more time on this slide, especially in the 21st century, where families are busy, both parents are working outside, and even when the family get together, everyone is busy on their devices. So parent-child connection is quite crucial, and it plays a major role in healthy as well as child in need for help. Parental supervision and availability. Mom and dad should not make an excuse because they're busy working. They cannot attend to their children's needs, especially something is not tangible, i.e. the mental and psychological needs. School connection. How many times parents go and check on their children, talk to the teachers, to the guidance counselor, and make sure that their child is performing, successfully performing in school, but equally important, comfortably settling in the school environment. Because as I mentioned earlier, some of the environmental risk factors, history of bullying that the child is exposed to by peers, and most of the and one of the common places is school. Do not shy, do not hesitate to use to make use of religious affiliation, providing it is used in an authentic in an authentic and appropriate way, because there are many practices that we know in the Muslim and Arab world does not necessarily relate to the religion nor to the right and appropriate practices. And keep in mind, of course, keep away from deviant peer group. Safety planning is very important, and I'll just give you a second to look at it quickly, and you may want to review it later on. The one important thing is spend enough time, check about suicidality with the child and the youth. And do not take, I don't know, or silence is an answer. So always try to to check for it, to probe more for it, and hopefully, if you have the clinician or the psychiatrist, if they develop a rapport with the patient, hopefully there will be a trust, and they will be more comfortable sharing if there is any safety concerns. Of course, contacting family members and friends, making a contract. Like I always discuss with my patient toward the end of my assessment, ways of ensuring that the youth is safe. Because maybe at the time when you see them, they're okay, no suicidal ideation. But later on, it's very important to work with the youth and the family on safety planning and how to reach or seek for help if needed at the time of acute suicidality. A question: which of the following antidepressant is approved for children and adolescents in Canada? And I'll give you 5 seconds to answer the question. And the answer: none to date. That doesn't mean we don't prescribe medication. We do, all of us, like family physician, pediatrician, psychiatrist, and needless to say, child and adolescent psychiatrist. Of course, we use the guidelines that are available. However, our neighbor country in the US and many other countries around the globe, they have approved some antidepressants for treating depression in children and adolescents. And on the top of the list, fluoxetine. Only in US, they also give it. They allow it for children start age 7 and above. Escitalopram, ages 12 to 17. The most effective is fluoxetine, and the least effective nortriptyline, and the most tolerable fluoxetine, and the least is imipramine. Non-FDA approved paroxetine, citalopram, sertraline, fluvoxamine. However, I can tell you all of these medication and others, among the SNRI and other medication working on the dopamine, have been used in youth, mostly in youth actually, less likely in children. Any support to this use of the medication? The studies there are a handful of studies, and I, for the sake of the time, I just wanted to discuss one of them, which is the treatment for adolescents with depression study known as TADS. It's as you can see, NIMH funded, so no bias or alliance with industrial and pharmaceutical companies. It was multi-center, fairly represented sample size for ages 12 to 17 for kids diagnosed of major depressive disorder. The aim to compare the efficacy of fluoxetine alone, CBT alone, cognitive behavioral therapy, combination of fluoxetine and CBT compared to placebo at 36 weeks with 1 year follow-up. The findings at week 12, not surprisingly, very positive for the combination treatment of fluoxetine and CBT versus fluoxetine comes second with less response when only applying CBT, needless to say, placebo. However, as the youth continue in therapy, you can see the CBT start to catch up, and the difference is actually close between the combination and the fluoxetine alone. However, still the combination is superior or above all. And at 36 weeks, you can tell that the difference has been closed. And I did not have it with me this time, but even at a later time, the placebo was not that much difference than the rest. which tells you, something we know it is high in children, and the placebo effect is relatively high in children and adolescents. Predictors of positive treatment response in TADS: younger adolescent, less chronically depressed, high functioning, less hopeless with less suicidal ideation, fewer melancholic features, fewer comorbid disorders. In 5 years, 196 continued to follow. 96% eventually recovered from the index episode of major depressive episode within 3.5 years. Nearly half, 46% of those who recovered, they became depressed again in 5 years, regardless of the initial treatment they received. Girls were more likely than boys to have repeat episodes. Those with anxiety disorder were also more likely to have a recurrence. This study is another one. I don't think I have the time looking at my watch to talk about it, but very interesting. They have different arms where those who did not respond to SSRI, they try them with another SSRI alone and with CBT versus Effexor alone and with CBT. And this is a very important study. Definitely the combination has been always superior. CBT plus a switch to either medication regime showed a higher response rate, 55%, than medication switch alone, as expected. No differential effects on self-harm or SI. And there was no necessarily difference in the response rate between a second SSRI and Effexor. However, this is very important, more side effects with Effexor. And this is, I'll just leave it for you to review and later. Tricyclic antidepressant, and those like me who studied or they attended the training where tricyclic antidepressant were the only available, or maybe, yeah, the only available antidepressant, plus of course the monoamine oxidase inhibitors and others, but it was commonly used 30, 40 years back, and maybe some still use them. I can tell you they are quite effective. And there is nothing wrong to use tricyclic if you know how to use it. It's not the only, but however, there are concerning issues when it comes to the high lethal risk in overdose, especially with youth, if they are if some of, as you know, some of them are quite impulsive. So this is something to be very cautious. So with the presence of the new antidepressant, SSRI, SNRI, and others, I wouldn't at all advise anyone to use tricyclic antidepressant in children and youth. Needless to say, the side effects, which can be really terrible, the anticholinergic, central and peripheral, antihistaminic, and alpha-adrenergic antagonism, and the risk of cardiac problems. Other antidepressants are available in the market, and as you can see, these are some of the common side effects you have to keep in mind. I wouldn't recommend using bupropion as a first or a second line. And if I have to, it has to be really indicated, and maybe in combination, start with low dose, not necessarily to go higher than 300 milligrams. Venlafaxine, this might be a bit of an old slide, because nowadays I can see, I use it, and my colleagues, talking to many colleagues in Canada and elsewhere, we're not feeling more comfortable using it, but also for anxiety, which in case, as you know, in 70% of the time they coexist. Mirtazapine, not as a primary antidepressant, but the sedative effect can be really good for sleep at night, and it can give some augmentation in addition to the other side effects. Always you have to educate the youth, of course, and children and their parents about side effects. So weight gain is quite an issue. especially in the case of girls. The L'Occitane, we have to educate youth and parents and children about the common side effects. And I just added one of the newer antidepressant, which has been introduced and been started by some colleagues. And there are a few studies about on what the Oxytine, the Trincolex in children, in adolescents. Placebo effect, I mentioned it, typically very high in most medication. Studies of antidepressants in both children and adolescents reveal approximately up to 30% placebo rate. In pediatric antidepressant trial has been the high 94% placebo response as by bridge. Overall response rate to antidepressant are about 65 at the highest. Consequently, about half of that is due to placebo. True antidepressant response rate is about 35%. Remember, the average length of depressive episode, not chronic, is 6 to 9 months without treatment. Again, presenting this, and this is maybe one of the argument the Canadians or maybe other school of thoughts, they don't want to expose children too early for antidepressant, is the high rate of placebo. And anyway, no matter what you do, within 9 months, the youth might recover. However, the key thing you have to keep in mind that you have no guarantee during this 6 to 9 months that the youth might further deteriorate and indulge themselves into risky behaviors or may lose their life altogether. So we have to be careful. And whenever when we make decision, when we make recommendation to start antidepressant, if ultimately the parents and the child have the final say on it, but you have to educate them about the pros and cons of treating with medication. And lots to be said, but this is maybe enough for now. Black box warning. As you probably, some of you might heard of this. In 2013, there has been a global concern about increased suicidal ideation among youth and young population when treated with antidepressant, and the prevalence was about 2% compared to youth on no medication. And the FDA Public Health Advisory issued a black box warning in October 2014 after 1 year of careful study, unbiased by pharmaceutical company. The good news, fortunately, although there is an increased ideation, we know it, it is not currently believed that there is an actual increased rate of completed suicide. Best available data from controlled trials and health record database alike show that SSRI treatment significantly decreased suicide ideation and suicide attempt in young population. And again, the time doesn't allow, because there were some countries who elected to stop or to warn people or discourage clinician and prescriber from antidepressant. And the next thing that they have noticed, the suicide ideation was in the rise. Question. With uncomplicated brief depression or mild psychosocial impairment, would you start with medication? The answer is no. And it's always recommended to go with psychotherapy. CBT and IBT is equally efficacious for mild depression in youth. And in summary, I would like just to conclude, because I have about 7 minutes to complete my 45 minutes presentation. You can read it yourself. And this is very important. Always, as I mentioned earlier, start low and go slow up to adult doses. Only make one change at a time. Target symptom cluster, not just the diagnosis. Think alliance rather than compliance. What I mean by that, you talk to the youth. You just don't. It's not just you prescribe and you expect the youth to comply. The current medical practice is to have the patient be part of the decision making. This is what we mean by alliance. One critique of pediatric antidepressant trial has been the high, as I said, placebo response. But again, you educate the parents, the youth, you examine the pros and cons, and then go with the treatment plan. Not all youth presenting with the same level of depression necessarily they end up on medication. But again, youth are different in their needs and depending on the precipitating and or the perpetuating factor of the underlying depression. So you have to keep that all in mind. I think I've already covered most of this. So fluoxetine is number one antidepressant recommended for youth and children 7 and older. It's very important to monitor side effects. It's very important also to educate the family and the child and the children and youth about these side effects and respect their preference if they elect not to go for medication. Among all the important side effects, suicide ideation usually, if it happens, it peaks in the first 6 weeks since the medication is started, or every time you increase the dose. So keep close monitoring. If you cannot see as a psychiatrist, busy clinic, have the family physician and other medic or nurse practitioner to monitor the progress. And check for any side effects, including suicidal ideation or increase in suicidal ideation. I already mentioned some of that. ECT, not much mentioned, at least in the Western, in Canada, for kids, for children and youth, but it is a common practice, especially in young adults. Needless to say, the older population, and it's quite effective through convulsive therapy. But the studies are still, I would consider, humble and to tell us the long-term impact of ECT, but the benefits are quite obvious. The last component of my presentation is psychotherapy, and there are different forms of psychotherapy. However, before I proceed, I would just want to emphasize in children and adolescents, it is very important, as we always teach in psychiatry, the best treatment model or the ideal today, the ideal treatment model is the biopsychosocial. If it's true if it's recommended in general psychiatry, it is very true in children and adolescents. So don't think that giving fluoxetine to 13-year-old or me 16-year-old will take care of the depression. You've got to really work with the child, family, and school, and maybe others through the biopsychosocial model. Among the psychotherapeutic intervention available, CBT has been studied and proven to be quite efficacious. Replicated studies showed with beyond doubt that it is very effective in all ages as well in youth. And relatively easier to find CBT therapists, one of the advantages. However, some of these disadvantages works better with those with more secure attachment. And again, I personally believe if you are applying CBT, that doesn't mean you don't consider interpersonal relationship. You don't consider psychodynamic. So maybe this is one of the things where when we think in boxes, that if I'm applying CBT, I cannot think of anything else. So that's not right. Again, with youth, they have role disputes, interpersonal conflict, transitioning from young age to puberty, from elementary school to middle and high school. Parents divorced, then changing houses, changing cities, maybe, and so on and so forth. So it's very important, and it's also have been found to be effective. When we talk about psychosocial, as I said earlier, we work with the youth, but also we work with the parents and school, and maybe others. If you face a child with limited or partial response, always good practice to reevaluate the diagnosis, look for comorbidities, check on adherence to treatment, evaluate or examine if there is any negative events happening at the time, and then, needless to say, review the quality of the treatment and the family functioning and psychopathology. Always not to forget doing physical exam. You're a psychiatrist. Before that, you're a medical doctor. So you have obligation if physical exam is not done by the family physician or another colleague, you have the obligation to do baseline and as needed investigations, including thyroid, and anemia, and what have you. So some of the some medical problem, either it's the cause or can complicate the underlying depression. I'm actually exceeded my time with 5 minutes, so I'll leave the summary for you to read it. And thank you all for your for all the audience for listening to my presentation. I hope you find it of benefit to you. And I wish I am with you in person so we can enjoy some of your valuable and important questions and comments. With that, I would like to conclude by thanking Professor Abdul Javeed and Professor Muhammad Waqar Azim and all respected professors in the scientific committee of this conference for inviting me and accepting my presentation and this and the second International Psychiatry Conference in Lahore, Pakistan. Wassalamu alaikum wa rahmatullahi wa barakatuh.